Good afternoon, everyone. My name is Dr. Lisa Tartaglia, and I'm coming to you for You Only Die Once with a very special guest, Dr. Corinna Muller. Dr. Muller, can you go ahead and introduce yourself to our audience?
Sure. I am Corinna Muller, and I am board certified in obstetrics and gynecology, as well as maternal fetal medicine, and kind of here to talk about some of those sad cases in my field where we talk about perinatal hospice.
Dr. Muller and I met when we were in medical school. We started med school in 1999 and graduated in '03. And we do a lot of talking and communicating. She was one of my BFFs at school, my confidant. We had 4 people that were in our study group, but we're always on a group chat with our friend, Dr. Simpson. And the two of us, throughout her career, I've told her a lot about my palliative medicine career. And I thought it was very interesting because sometimes we get very hyper focused in our specialty of how your specialty really overlaps with my specialty. So would you mind telling the audience about your journey of what made you decide to do maternal fetal medicine in addition to obstetrics?
So I started out in a family medicine psychiatry residency, and then whenever I would do a delivery or be on the obstetrics unit, I was like, wow, I just really need to do this. And I had considered doing obstetrics as a career earlier in my medical school training, but I pushed it away. I said, I don't know that I have the time or the tolerance for the litigation that could potentially come out of an obstetric career. And so I really pushed it away and tried to do something different that I didn't feel that I loved. And so I switched residency programs, and then, getting trained in obstetrics and gynecology, I really loved ultrasound, and I had some pretty influential cases of patients who lost babies early, like recurrent pregnancy loss. And I really felt like I could reach out to them and have them be my patients and help them. And so that's kind of how I ended up in perinatology or maternal fetal medicine. Was I really love ultrasound, prenatal diagnosis, and I really love just helping people through tough pregnancies.
For those of our listeners and viewers that are watching our video today, can you just explain to them of after the 4 years of medical school, how long your training is in addition to that?
Sure. So my training kind of went in a pathway of I did an internship that first year out of medical school. The training that I did counted as a 1-year rotating internship. And then I did a 4-year residency in obstetrics and gynecology. And then I did a 3-year fellowship training in maternal fetal medicine. And so then I was done. So it was like 8 years after medical school is when I, finally was done with all of the training and became an attending.
Right. And in addition to all that training, what a lot of people don't realize is there's a lot of tests that we have to take in order to become physicians. So Dr. Muller had to get board certified in obstetrics and gynecology, which didn't it involve also an oral exam and written?
Yes. So that OBGYN board certification is a written exam. And then after that, like a year or two later, it's an oral exam. And then you become board certified. And then with maternal fetal medicine, it is a case list that you build up for a year. And then you go and take an oral exam that includes research that you did, basically like a thesis. And they question you about that. And then a very large case list where you talk about multiple cases that are within that maternal fetal medicine realm. And they have like different, areas of maternal fetal medicine, like prenatal diagnosis, preeclampsia, maternal disease, like all these different, cases that have to meet the criteria for that. And yeah, so then you have to pass this oral test. And then after you get those board certifications, then you have to do maintenance of certification. And now it's just questions, not just, but, questions that you answer on a quarterly basis online. So they made it a little bit more, I guess it's user friendly for
Mhm.
the certification, recertification process, because we used to have to go down to Chicago and take an oral exam every, I think it was like 6 years, 6 or 7 years. And now it's all online. So um, that that's a lot better for people. And I think COVID probably had something to do with that.
Yeah, I know for myself, I'm so grateful that this year for my family practice recertification, I was able to do it all by test questions online.
Mhm.
However, it's still time consuming and costs the same amount of money as if we would go to Chicago. So
Yeah,
I'm happy that you don't have to continue to do the oral exams like you used to.
thank
Now,
goodness. Yeah.
yeah, thank goodness is right. Now, just out of curiosity, tell us what it's like, when you're seeing a patient, and I imagine in your practice they come to you because there's an abnormality, maybe on an ultrasound that's found by an OB, or how does a patient come to you? Would you mind describing that to us for us?
Sure, sure. So, my particular practice is referral only. And so midwives, either lay midwives, CNMs, physician assistants, physicians who do OB and family medicine, obstetrics and gynecology specialists, those are all people that can refer to me. I mean, anyone who's pregnant can come and see me. Um, and a lot of times it's because they either have a high risk condition maternally, or they've had a very unfortunate experience with their previous pregnancy, like maybe early preeclampsia or a preterm delivery, or a unfortunate, fetal demise, or, something happened and there was a major congenital or heart defect anomaly in their last pregnancy. And then a lot of them are coming to see me because they had an ultrasound in pregnancy that showed some type of fetal abnormality, so that we can further look and see if, I mean, because I live in Alaska, and so we don't have all the resources that maybe a large, metro medical hub would have. So, a lot of times I'm trying to figure out where they can deliver if there's like a major complex heart, defect, or spina bifida or something, unfortunate like that. So, yeah, so that's kind of how they get to me. I take everybody, all insurances. Anyone can refer to me. It's just that, they have to be referred. And yeah, so there's lots of different reasons why we'll see someone in the pregnancy.
Now, when you have a poor outcome, like say, for example, you have an anomaly that's found on ultrasound, how do you handle that discussion with the patient and the significant other?
Mhm. So, I mean, I always have to take a deep breath before I go into the room. Um, I can see the images in my office that the sonographer is taking in real time. Um, and, I review those before I go in to speak with our patients. And, you know, I always need to remind myself that the words that I say are going to be with this family forever. And, to always make sure that I have a very open mind, and let them know that, I'm really sorry that this is the first time that I'm meeting you. But I have some hard news. And, let them know that if they have questions at any time during the process, and I usually ask a lot of questions too. I just, you know, make sure that they know that I'm open to any of their questions, that I'm here for them after they leave the exam room, for questions, and that we're here to support them through whatever process it is that they need to go through in that grief process of finding out that something is going on with their baby that, may be life altering or even lethal.
Hmm. Now, do you often see these patients just once? Is, is that usually your experience?
Typically not. So I would say that during a pregnancy that's complicated, I do have a lot of continuity with them, but not over time, like, years and years, and I'm delivering all their families, babies, and things like that.
Mhm.
I mean, that's just I'm not doing deliveries these days, and that's mainly because there's only a few of us in my state, and they need my expertise in other areas. And there's lots of people that can deliver the babies in the state. There's just not a lot of people who can do what I do here. So, I do see these people very often in their pregnancies when there is a lethal diagnosis, since I think that's what we're,
Mhm.
kind of focusing on today. Yeah.
Okay. Now, when these patients come to you, has the OB already that they're established with kind of broke some of the news to them, or is this, or some of them have no idea? Like, they're just coming to you and they have no idea what was found, and you have to deliver the news.
A lot of them will have kind of a generalized idea that, the reason they're coming to see me is not a great reason. Um, Sometimes some of these things are just the beginning step of a diagnosis with the outside ultrasound, like to diagnose a complex cardiac defect on ultrasound in a fetus. I'll tell my um, patients that it might take 3 or 4 ultrasounds to
Mm.
really get it right and get that perfect. But knowing, as a maternal fetal medicine specialist in Alaska, that we don't have the resources of like ECMO here for
Mm.
pediatrics. We don't have a pediatric cardiothoracic surgeon. And so, like, if I see a defect that needs to be delivered in, like, say, Seattle, Salt Lake City, Portland, because those are kind of the hubs where we can send people to that might be covered by Alaska insurances, um, that we make sure that they are delivering in the right place so that their babies can get the care they need right away. And then, of course, there can be, um, conditions where we know that there's not any intervention that can be done, and it's going to be an unfortunate prognosis of possibly a demise or a fetal death before birth or shortly after they're born, and that comfort care might be the only option.
Now, what techniques do you do to help like elicit from the parents in regards to that? Because in my line of work, obviously, when they meet myself or my colleague, Dr. Bone, and they know we're palliative medicine, sometimes even they don't have a full idea of what it is. But once we explain our our specialty, then they kind of will have an idea, so we can then lead into like a goals of care conversation. How do you do that with these parents?
I think, I mean, it kind of is universal in any of the questions that I ask them. In general, I will just kind of sit with them, um, make them comfortable, hand them, Kleenex, or, just give them the time that they might need to talk with each other about what it is that I just spoke with them about. Because I think time helps them to formulate questions about, surrounding it.
Mhm.
But I always tell them, I can talk to 10 different people about the same thing and get 10 different answers. So, if any of the questions that I'm asking you um, are tough, or, you know, it seems like, I'm not giving you the kind of compassion that you need in this situation, please let me know. But I don't know what each patient's desire is when they walk into this exam room, and by having them share what it is that they are hoping to achieve moving forward after getting tough news is something that I really need to be communicated to me. And that if it takes them time and they can't think of an answer, that we can work with that, and that they can call me back, they can come back for another visit. But that whole thing of letting them know that everyone has different reactions to the same news, and that we never know what to expect when we as the physician walk in there, and that they can help us be compassionate and help them by letting us know what they need after getting that information.
Mhm. Do you have any like bereavement services that are available for patients and families in Alaska that are offered before they even have the baby?
Yes, there so I think part of what I do is education. So I do have a genetic counselor that I contract with. And, they're really great at talking to people maybe more about the scientific reasons of what's going on, doing testing, trying to find out maybe why this happened. But there are some other palliative fetal care or neonatal care uh, programs. There's one at a local hospital here in Anchorage that if there's something going on and we know that the baby, let's just say for instance, high drops at a very early gestational age, so that's like when you have heart failure, or maybe there's a cystic hygroma, which is a condition of buildup of lymph fluid back behind the neck and around the neck and the face, and it can be associated with early heart failure and fluid buildup in like the lungs, around the heart, in the abdomen, really thickened skin that we can see on ultrasound. And there's many different reasons why these things can happen. It can be a viral exposure, it can be an antibody incompatibility called alloimmunization in pregnancy. So we're getting to some complex things here of reasons why these things can happen. But in the case of high drops, where we know that it's probably going to end up being a fetal demise in utero, or if maybe there's a congenital defect that causes the lungs to not develop so much, like high drops. High drops cause a lot of pressure on the lungs and they just don't grow. And so a baby could be like 7 or 8 pounds near term, but if their lungs didn't develop, they're not going to be able to breathe and sustain life after they're born. So, talking with them about that and what they might want to do in their pregnancy. Do they want to try to have the baby by C-section and spend some time with that baby alive, so that the stress of a labor doesn't interfere, and that the baby is born deceased? Do they want to try to have a vaginal delivery? Some cases there might be a contraindication to even try and get the baby out naturally, because they would get stuck and need to have a C-section anyway. But the other thing would be, do they want pictures with the baby? Do they want to have family members hold that baby before baby passes? Do they want the NICU to be present to see if there's a possibility of resuscitating this baby? Do they want to even attempt to place life-sustaining measures or intubation? It's really, it's a lot of questions. And they do have a specialized team that talks to patients. And I've, utilized that, quite a few times. I mean, it's unfortunate. They're very helpful because I especially remember one case where a family was in serious denial about the things that they were told about the prenatal diagnosis. And after encouraging this family to see that palliative care team a few days actually before the delivery, I think it finally, kind of settled in their hearts that this was going to be what happened. And I was very thankful for that, because, the stages of grief are just so, I mean, you don't know how long someone might sit in denial, or, just feeling like, this isn't real, or, this doctor isn't right, or there could be a miracle. And yes, there can be. And I am not here to take away anyone's hope. And I usually tell my patients that too.
Yeah.
But yeah, making sure that people are prepared for the end and what they want and desire is very important.
Yeah, and I think that's interesting to circle back. That's what I do with my line of work. Although my patients are terminally ill, they have lived some sort of life. Now I do take care of pediatric patients, and that's can be very, very sad. But it is nice to know to allow the patients to have their levels of grief before the passing, and then also to know what they would like at the time of the passing. Now, just out of curiosity, do you attend any deliveries now or no?
Yes, there are many deliveries that I'm a part of, especially if it's a planned C-section, or if the OBGYN wants me to be there, during that time. So a lot of the ones that I do attend are people that I've seen quite a bit, throughout the pregnancy. But I'm not usually the main delivering physician. But they know that, I definitely am there to support them.
Okay. And have you seen the evolution of healthcare change in your practice? Like, how had the advancement of ultrasound, other different types of testing changed the way you practice medicine?
I would say that fetal care centers around the United States have really changed the way that medicine is practiced in my field, and ultrasound technology, because we can find out so many things about a baby's status so early. I mean, my ultrasound machines are amazing in
Yeah.
my practice, and um, it gives us quite a bit of time to plan when we see a major anomaly early in the pregnancy. And the fetal care centers around the United States, I'm not really sure, there might be like 30 of them. They offer early intervention, like if there's fetal surgery that needs to be done to correct a spina bifida finding prior to delivery in utero, and they go in there, they fix it. They have a pediatric neurosurgeon going in there, with they go into the uterus and then they sew it back up afterwards. And knowing that an in utero repair of a situation like that has better outcomes than a post delivery repair of a major spina bifida, as far as the babies being able to have, good neurologic function at age 2, bladder function, there's plenty of things that, studies that show that in utero repair has better outcomes than waiting until after the baby's born. So I'd say like ultrasound, just, the whole reason, one of the main reasons I went into this field, just the advances in ultrasound and knowing that we can see so much prior to delivery to prepare people for, unfortunate situations, is something that I have really appreciated, because there's nothing worse than not being able to prepare a patient for like a major cardiac defect, or the fact that maybe their baby's going to end up in the NICU, or that their baby's not going to survive. And I can only imagine how difficult that may have been with the limited imaging modalities that we had, maybe even 20 years ago compared to now.
Yeah, you have such a wealth of knowledge and a vast area knowledge. It's incredible to me. Now, just out of curiosity, what do you and your office staff do to help yourselves recover when you're having these type of tough conversations? Because I imagine it affects the sonographer, your nurse, anybody in your office. It's got to be hard. These are heavy topics. How do you prevent burnout?
Well, the first step is communication. When I walk in, before I even walk into a room with a patient, I let my front desk staff, my manager, the medical assistants, I let somebody know that this patient is not going to be, this patient is going to be upset and they are grieving. So let's treat them accordingly and make sure that they have a place to grieve, and let them, exit, in a way that is respectful of that. And so, sometimes people might not want to come back to a place where they associate it with a traumatic experience. And so, I try to make sure that it's like a trauma-informed type setting where, people are like, okay, I can understand in room 2, they were diagnosed with this, so maybe we want to put them in room 1, next time, or, just acknowledging their trauma. And then knowing that it's not just associated with the patient, but the staff, like you were saying. And so, we have a very close-knit staff. I've had my same kind of base 5 people with us for 5 years. And we bring our dogs to work. They hang out in non-clinical areas. We take walks. We hang out with the dogs. I even let my medical assistants bring their babies to work for the first 6 months during COVID, just so, that kind of family supportive environment is there. And, I really literally have an open door policy, and people can come and talk to me about anything. And, these things are hard to not take home. And, I use music, and the dogs, and just reaching out to friends and, family members, when I've had a hard day, just, to kind of hang out with music and meditate a little bit, forget about medicine. But, I think that in the end, it is a very emotional field. I don't know how you do what you do every day. And I respect you for that. And I know that you have so much compassion for your patients and teaching them about what it means to live and what it means to, die.
Yeah, and I think even with your field, I just know for myself, being a mom myself, having two children of my own, I can't even imagine putting myself in the shoes of some of your patients and what they have to deal with. So they are so lucky to have you in Anchorage, and that you have such an open door policy with your staff, and as well as just that family feeling. People must come into your office and just feel right at home, which is really awesome.
Mhm.
Because then you're very approachable, so patients can ask the questions that they need to in order to heal and to know the next steps.
Mhm.
I really appreciate you taking the time to share some really heavy stuff with us. Both myself and Dr. Bone are very intrigued because we're very in our box of palliative medicine in the state of Florida. We see mostly elderly patients that have lived a
Mhm.
full life. But I think it's really important to know that there are different stages of grief, and they occur even perinatal. And we need to be, as a medical community, aware of that and accepting of it, and help those that may need our help. Um,
Mhm.
Dr. Muller, I just want to, before we wrap up, I want to just spend a few minutes talking about your book. You're an author now. Can you just tell our viewers about your book a little bit, and where they can find it? Because I'm so proud of you.
Sure. Thank you so much. So, as I alluded to earlier, I love music and I'm a musician and I actually trained professionally in undergrad. I do have a music degree and I play the flute. And I feel like music has taught me so much. And, just like the basics of music, having played the flute since I was 11 years old, dynamics, practice, repetition, performance, all of these things that we practice for in music and get ready for a big performance and a finale, are things that you can kind of extrapolate and apply to your own life. And so this book that I wrote combines coaching principles because I'm a physician coach, and it also throws in some musical principles and some business principles on how you can use those ways of achieving goals in an 8-step method. And I originally wrote it for physician women, but like after it's all said and done, anyone can read this book. It's not targeted specifically towards physician women. It's targeted towards anyone who has a goal and wants to achieve it and wants to do that in a stepwise fashion. So that's the book that I wrote, and it's out there now, and I'm an author now, and it just feels really crazy.
Well, all I can say is we've come a long way from that dark, dreary classroom in Erie, Pennsylvania. I will never forget the day we met, and I'm so grateful for you and my friendship also with Dr. Simpson. And you guys led me to keep trying, keep don't lose my compassion, and just keep at it. And I think we all built each other up. But you have now gone to another level now as an author, and I am just so proud of you. I cannot wait for my signed copy of your book. And I agree. I think anything in life, we all hit a spot where we kind of need to figure out how to get to that next step. And sometimes we're paralyzed with our own thoughts. And books like you wrote are going to that you have written is going to help others to read it when they're in that stuck spot. And I can't wait to see how many lives you transform. And what I love about your book is, me, 100% Italian. I love your title. And I just want to tell everyone, read Dr. Muller's book. It's going to make you become an octave higher in life, and keep shooting for the stars or the Northern Lights in Anchorage, Alaska.
The North Star.
Yeah, and the North Star, right? But thank you so much for joining us today. Thank you for opening your heart some tough topics. I can't wait to get up to Anchorage and tour your office one day. And I really appreciate you taking the time to meet with You Only Die Once. And thank you, my friend.
Thank you.